put the bija, like a farmer. Farmer will sow the seeds. Adu playground clear admele, when we put the seeds, then these seeds will form new crops. That is called healthy marrow. So
Launch of Apollo Cellular and Bone Marrow Transplant Unit. In fact, it is a huge sense of pride, not just for Apollo hospitals, but also for Bangalore and Karnataka to have a unique facility closer to patients' home in South Bangalore, where newer advanced treatments such as cellular therapies and complicated or complex bone marrow transplants can be performed. First of all, I would like to invite our CEO, Mr. Akshay Oleti, under whose leadership Apollo Hospital has seen transformational growth, particularly with regards to the Oncology department, and we hope that under his leadership it continues to remain so. I would also like to invite our consultant colleagues, Dr. Neema Bhat, Dr. Vishwanath, Dr. Aditya and Dr. Poonam, who specialize in cellular therapies and bone marrow transplantation and will be leading the program at Apollo Hospitals, Bangalore. I would also like to invite Mr. Faraz, who is the Vice President of Sales and Marketing, and we hope that he will help execute the vision that Apollo defines and make this into a center of excellence. I would also like to invite all of the distinguished media guests who are here today. I think you being here has actually given us a special occasion so that we can inform the people of the facilities that are being launched so that they can avail of these facilities closer to their home. Cellular therapies and bone marrow transplants are unique treatment options which are not available in every hospital, and Apollo Hospital is really fortunate to bring this facility closer to home. And as you'll hear over the next half an hour or so, what exactly these treatments are and how it is going to transform our patient healthcare. So thank you for each one of you being here. I would also like to welcome the Apollo Marketing, Mr. David, Mr. Shashi and Mr. Chandru, who are all here helping make this happen and be executed flawlessly. Having said that, I think launching this unit is going to be transformational, both in terms of improving clinical outcomes or clinical excellence, in terms of providing compassionate care to people, particularly based out of South Bangalore, and bring in more and more innovations as we go along, which Apollo is known and famous for. I would like to thank you very much.
Good afternoon to everyone, all my esteemed colleagues, Mr. Akshay sir, our marketing team and esteemed members from our media and press. First of all, I'd like to take this opportunity to thank you for coming and participating in this event along with all of us, helping us bringing this message out into the community and seeing how we can take this forward from whatever we've already been doing. So I think Apollo by itself has been doing excellent as far as oncology goes, and all my esteemed colleagues will come one after the other and probably talk about it. And today we are specifically gathered to talk about bone marrow transplants and cellular therapies that have been going on in Apollo, but this is a new phase. We are launching a new bone marrow transplant unit, and we are going to add to the excellence of care that Apollo is already offering. I'll start the short talk today with a small story. It was a regular OPD day. I had a 32-year-old male man sort of walk into the OPD with his high school sweetheart. They were engaged to be married about 3 years before. He had been diagnosed with lymphoma, which is a type of very severe blood cancer. He had undergone chemotherapy, about 3 lines of chemotherapy before that, and had only shown partial response. His disease had come back each and every time after the chemotherapy. He was very heartbroken. His fiancée was confused. What do we do? Do we go ahead with the marriage? Where are we going with the treatment of this disease? Are we really going to see cure? His lymphoma seemed to be an aggressive variety which had responded initially to chemotherapy upfront but had a tendency to come back. So we designed a plan so that we could give him what we call salvage chemotherapy or strong chemotherapy, and then do what is called an autologous stem cell transplant. So this is what we are going to talk about. We were fortunate enough to collect his stem cells, give him high-dose chemotherapy. He was in the transplant unit for about 2.5 weeks and got discharged. He is now about 2 years post-transplant and doing very well and disease-free, happily married. So what is this? What exactly is this treatment modality we are talking about? So briefly to explain what is a bone marrow transplant. Bone marrow is nothing but the soft tissue that is present inside bones, and this is sort of considered like the factory where your cells are made. So your red cells, white blood cells, your platelets are all produced in this factory. And in severe life-threatening diseases like leukemia, it could be lymphoma, can be aplastic anemia. In genetic disorders, especially in children, it can be thalassemia, again aplastic anemia, sickle cell anemia. They are all blood-related disorders where this bone marrow starts malfunctioning. It's basically not functioning normally. If you've heard of kidney transplant, liver transplant, so a normally functioning organ has to be given back, to the patient, so the organ can start functioning normally again. Bone marrow transplant is similar but not the same as a solid organ transplant in many ways. So it involves replacing the diseased or defective bone marrow with healthy stem cells. It can be taken from the patient's own body in diseases like lymphoma or myeloma, or it has to be taken from a matched donor. We do what is called HLA typing and find a fully matched donor or an appropriately matched donor and perform this procedure. These stem cells then find their own way into the bone marrow and start the generation of a healthy blood and immune system. In simple terms, bone marrow transplant gives patients, especially children and young adults, a second chance at life. We almost consider it a rebirth because they are being brought back from the brink of death and given a new lease at the chance of life. Why is it that a dedicated BMT and a cellular therapy unit important? So in a multi-specialty hospital like Apollo, that has been around for almost 20 years now, we have been doing all sorts of very high-end procedures, including cardiac, liver, kidney, also some autologous transplants. But the goal is to offer what we call allogeneic transplants and CAR T-cell therapy or other cellular therapies that are now the newest technology that is coming to the forefront for treating oncology patients and patients with blood and cancer disorders. So we believe that a transplant unit cannot really exist in isolation. It needs the backbone of a multi-specialty hospital. Patients should be able to have access to advanced diagnostics, infection control, the appropriate critical care with the right intensivists being able to take care of these highly complicated patients. Radiological services, transfusion medicine, so the right blood bank services are required, and a multidisciplinary medical supportive care all under one roof. Bone marrow transplantation is not a single procedure. It's not like taking the patient to the OT, replacing the deceased liver and giving a new liver. It is a complicated procedure, and it's a journey that requires the coordinated efforts of hematologists, oncologists, infectious disease specialists, critical care physicians, highly skilled and trained nurses, psychologists that help us counseling, and advanced laboratory systems. Having all these experts and services seamlessly integrated in what allows us to deliver safe, efficient and holistic care to every patient is what is going to make this Apollo cellular therapy and blood and marrow transplant unit significantly different. So what are the high-end specialized procedures that we perform in our unit? So this unit will be designed to meet international standards of safety, sterility and infection control with positive pressure rooms, HEPA filtration and dedicated nursing teams that are trained in transplants. We are proud to offer the full spectrum of cellular and transplant therapies, including what we have already been doing, autologous bone marrow transplantation, where this patient's own stem cells are taken away from their body, stored, and then after giving them high-dose chemotherapy, it's reinfused back so that they can be cured of their blood cancers. Allogeneic transplantation, which is where stem cells are obtained from a matched donor, and this is usually used in treatment for conditions called leukemia, aplastic anemia, genetic blood disorders like thalassemia, sickle cell anemia, and so on and so forth. Haploidentical transplants, which is where we don't find a full match for transplants from a donor in the community or from the family. So we may have to use what is called a 50% donor, and my colleagues will be elucidating or explaining a little bit more in detail about each of these techniques of transplant. Pediatric transplants, which is also my specialty, which is one of our strongest focuses, addresses the children with congenital bone marrow failure syndromes, thalassemia, sickle cell anemia, so genetic blood-related disorders, leukemias, and lymphomas. Pediatric transplants demand a very meticulous expertise and emotional support for both families and the community, both of which we're going to be able to provide. CAR T-cell therapy, about which Dr. Vishwanath, my colleague, will be talking about, and other advanced cellular therapies, we will talk about a little more in detail in the event of today's gathering. Specifically pediatric transplants, when we hear the term bone marrow transplant, most people in the community, patients and families, think that it's a last resort procedure. It is going to be something that is going to put the patient at a high risk of mortality. The patients are not going to survive beyond this. But in the world of children's medicine, it's often a life-saving treatment. So we know that patients with blood cancer only have few months to live if they are really not responding to chemotherapy. So what is it that comes to the forefront trying to save these children with blood cancers is bone marrow transplants. It's something that gives the young child a real chance of growing up healthy and fulfilling their dreams and being able to do their normal activities like going to school, playing with their friends, etc., etc. So why is it that pediatric bone marrow transplant is special? And why is it so highly complicated? So these stem cells are like the seeds from which all our blood and immune cells grow, as I've already told. But when a child's own marrow stops working or it produces abnormal cells like leukemia, replacing it with the healthy ones can completely replace or improve their blood and immune system. When do children need a bone marrow transplant? So what conditions? I've already sort of given a briefing. Mostly in blood cancers like leukemia, lymphomas, especially in patients who are not responding to upfront chemotherapies. Bone marrow failure syndromes like aplastic anemia, we have something called Diamond Blackfan and Fanconi syndrome, where the child's bone marrow is just not working or it's failing. Genetic blood disorders like thalassemia, sickle cell anemia, where patients have severe anemia, organ dysfunction because of various blood transfusions, and these children will require bone marrow transplant as a form of permanent cure. Inherited immune deficiency, we call it SCID or combined immunodeficiency, where the child's immune system is just not working normally, and immune system also originates in the bone marrow. This is where bone marrow transplants are also helpful. Metabolic and genetic diseases, where they're born with diseases where they can't really produce the required hormones and enzymes that are required to maintain normal life. That is another part or area where bone marrow transplants really come to life. What makes pediatric transplants unique? Why is it that a dedicated transplant unit is required to do pediatric transplants? So treating children is very different from treating adults. Children are not just small-sized adults, is what most pediatric people will tell. Their bodies are still developing, their immune systems are quite delicate, their emotional needs are immense. They always come with attached families who require significant support in counseling them, taking them through this complicated journey. So pediatric transplant requires meticulous medical care, which is, should also be combined with empathy, counseling, and significant family support. It involves a coordinated team, which usually comprises of pediatric hematologists, intensivists, infectious disease specialists, and nurses and psychologists and nutritionists, which we require all of them to come together working under the same roof so that this child can have a safe and healthy course. At Apollo hospitals, we perform all types of pediatric transplants, bone marrow transplants, autologous, allogenic, and haploidentical transplants, as well as matched unrelated donor transplants, where patients can either have a match in their own family, a full match, or a 50% match from their own parent, or a match from the community or a pool of bone marrow donors. So specifically something like haploidentical transplant has been a significant game changer for Indian families, because not all families are able to afford the bone marrow that comes from the community or a pool of donors, because it costs quite heavy. So I'd just like to mention another small story over here before I start closing my speech. So we had a 6-month-old baby who was diagnosed at the age of 5 months with severe congenital MDS, myelodysplastic syndrome, which is basically a disease where the bone marrow is not functioning or it's failing and would lead to cancer or acute blood cancer. The child was the only child, no siblings available in the family, and we did not have enough time to actually find donors from the community. The initial search, we did not find any fully matched donors. Father thankfully had a 50% match with the child, and we went ahead and did a transplant for this child, and the child is now about 3.5 years post-transplant, free from his MDS, does not have blood cancer, and is starting to attend school. So something as magical as giving a second lease at life is what bone marrow transplants are meant to do. Every successful transplant is not just a medical triumph, it's a story of a family's strength and a child's resilience. So I've seen children who've not been able to get out of their room, especially in immunocompromised diseases. After transplant, they're able to go out, mingle with their friends, play, go to school, and have a normal, healthy life. So as part of the broader vision, with the help of our Apollo marketing team, our corporate office, Mr. Akshay sir, we really thank the Apollo management for giving us an opportunity to start the state-of-the-art transplant and cellular therapy unit, and hope to be able to give back to the community leaps and bounds more than what we've already been doing. Thank you for joining us.
ನಮಸ್ಕಾರ ಎಲ್ಲರಿಗೆ. ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ಹೇಳಿದ ತಕ್ಷಣ ಏನು ಮನಸ್ಸಲ್ಲಿ ಇರುತ್ತೆ, ಇಲ್ಲಿಂದ ತಗೊಂಡು ಅಲ್ಲಿ ಕೊಡ್ತೀವಿ, ಕರೆಕ್ಟಾ? ಕಿಡ್ನಿ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ಅಂದರೆ ಇಲ್ಲಿಂದ ತಗೊಂಡು ಅಲ್ಲಿ ಕೊಡ್ತೀವಿ. ಹಾರ್ಟ್ ಅಂದರೆ ಇಲ್ಲಿಂದ ತಗೊಂಡು ಅಲ್ಲಿ ಕೊಡ್ತೀವಿ. ಈ ಬೋನ್ ಮ್ಯಾರೋ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ಅಂದರೆ ಏನು? ವಾಟ್ ಈಸ್ ದಿಸ್ ಬೋನ್ ಮ್ಯಾರೋ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್, ಸ್ಟೆಮ್ ಸೆಲ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್? ಏನು ತೆಗಿತೀವಿ, ಏನು ಕೊಡ್ತೀವಿ? ಸೊ ಅದಕ್ಕೆ ಇಟ್ ಇಸ್ ಕಾಲ್ಡ್ ಸ್ಟೆಮ್ ಸೆಲ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್. ಈ ಸ್ಟೆಮ್ ಸೆಲ್ ಅಂದರೆ ಏನು? ವಾಟ್ ಈಸ್ ದ ಸ್ಟೆಮ್ ಸೆಲ್? ಸೆಲ್ ಯು ಆರ್ ಲಿಸ್ನಿಂಗ್ ಅ ಲಾಟ್ ಆಫ್ ಸೆಲ್ ವರ್ಡ್ಸ್, ರೈಟ್? ಸೆಲ್ ಅಂದರೆ ಬೀಜ. ಬೀಜ ಮಂತ್ರ, ಓಂ ನಮ ಶಿವಾಯ, ಎಲ್ಲ ಮಂತ್ರ ಮುಂಚೆ ಓಂ ನಮ ಶಿವಾಯ ವಿಲ್ ಬಿ ದೇರ್. ದಟ್ ಇಸ್ ಕಾಲ್ಡ್ ಬೀಜ ಮಂತ್ರ. ಇದೇ ರೀತಿ ನಮ್ಮ ದೇಹದಲ್ಲಿ ಬೀಜ ಮಂತ್ರ ಇದೆ. ವಾಟ್ ಈಸ್ ದಟ್ ಸೀಡ್? ದ್ಯಾಟ್ ಈಸ್ ದ ಸ್ಟೆಮ್ ಸೆಲ್, ದ ವೆರಿ ಪವರ್ಫುಲ್ ಸ್ಟೆಮ್ ಸೆಲ್. ಆಲ್ ಆಫ್ ಅಸ್ ಹ್ಯಾವ್, ಈವನ್ ಅವರ್ ಪೇಷಂಟ್ಸ್ ಹ್ಯಾವ್. ಸೊ ಸ್ಟೆಮ್ ಸೆಲ್ ಥೆರಪಿ ಮೀನ್ಸ್ ಈ ಬೀಜದು ಪವರ್ ವಿ ಆರ್ ಟೇಕಿಂಗ್ ದಿಸ್ ಪವರ್ಫುಲ್ ಸ್ಟೆಮ್ ಸೆಲ್ಸ್ ಫ್ರಮ್ ದ ಪೇಷಂಟ್ಸ್ ಬಾಡಿ ಆ್ಯಂಡ್ ಗಿವಿಂಗ್ ಬ್ಯಾಕ್ ಟು ದ ಪೇಷಂಟ್. ಸೊ ಎರಡು ರೀತಿ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ಇರುತ್ತೆ. ವೆನ್ ಸೇಮ್ ಪೇಷಂಟ್ದು ಸ್ಟೆಮ್ ಸೆಲ್ ಸೇಮ್ ಪೇಷಂಟ್ಗೆ ಕೊಟ್ಟಿದ್ರೆ ಇಟ್ ಇಸ್ ಕಾಲ್ಡ್ ಆಟೋಲೋಗಸ್. ಆಟೋ ಅಂದರೆ ಸ್ವಂತ, ಆಟೋಲೋಗಸ್ ಸ್ಟೆಮ್ ಸೆಲ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್. ಬಟ್ ವೆನ್ ವಿ ಹ್ಯಾವ್ ಅ ಡೋನರ್, ಬೇರೆ ಯಾರ್ದು ಮ್ಯಾಚ್ಡ್ ಡೋನರ್ ಇದ್ದರೆ ಅಥವಾ ಅನ್ಮ್ಯಾಚ್ ಡೋನರ್ ಇದ್ದರೆ ಅಲ್ಲಿಂದ ಸ್ಟೆಮ್ ಸೆಲ್ ತಗೊಂಡು ಪೇಷಂಟ್ಗೆ ಕೊಟ್ಟಿದ್ರೆ ದೆನ್ ಇಟ್ ಇಸ್ ಕಾಲ್ಡ್ ಆಲೋಜೆನಿಕ್. ಆಲೋಜೆನಿಕ್ ಅಂದರೆ ಫ್ರಮ್ ಹಿಯರ್ ಟು ದೇರ್. ಆಟೋಲೋಗಸ್ ಮೀನ್ಸ್ ಫ್ರಮ್ ಪೇಷಂಟ್ಸ್ ಓನ್ ಬಾಡಿ, ಪೇಷಂಟ್ ಸ್ವಂತ ಸ್ಟೆಮ್ ಸೆಲ್ಸ್ ಪೇಷಂಟ್ಗೆ ಕೊಡ್ತೀವಿ. But before giving the patient stem cells, what we do is make sure that the patients will have no disease. There are many indications for stem cell transplant. For autologous, andre same patient ke same cells kodake, there are few indications, not all. So limited number of cases like multiple myeloma, lymphoma and some childhood disorders. So in this what we do is first we give treatment. Now treatment can be 4 months or 6 months. ಟ್ರೀಟ್ಮೆಂಟ್ ಕೊಟ್ಟಾದ್ಮೇಲೆ ಎಲ್ಲ ಕಾಯಿಲೆ ಕಮ್ಮಿ ಆಗುತ್ತೆ. ದಟ್ಸ್ ಕಾಲ್ಡ್ ರೆಸ್ಪಾನ್ಸ್. ಕಂಪ್ಲೀಟ್ ರೆಸ್ಪಾನ್ಸ್ ಆಗಿರ್ಬೋದು, ವೆರಿ ಗುಡ್ ಪಾರ್ಷಿಯಲ್ ರೆಸ್ಪಾನ್ಸ್. ಎಲ್ಲ ರೆಸ್ಪಾನ್ಸ್ ಆದಮೇಲೆ ಏನು ಮಾಡಬೇಕು? ಮುಂದೆ ಕಾಯಿಲೆ ಮತ್ತೆ ಬರಬಾರ್ದು, ರೈಟ್? ಡಿಸೀಸ್ ಶುಡ್ ನಾಟ್ ಕಮ್ ಬ್ಯಾಕ್. ಕರೆಕ್ಟ್? ನಾವು ಟ್ರೀಟ್ಮೆಂಟ್ ಆದಮೇಲೆ ಪೇಷಂಟ್ಗೆ ಒಂದೇ ಕ್ವೆಶನ್, ಮತ್ತೆ ಕಾಯಿಲೆ ಬರಬಾರ್ದು. ಹೌ ಡು ವಿ ಎನ್ಶ್ಯೂರ್ ದಟ್ ದ ಡಿಸೀಸ್ ಡಸ್ ನಾಟ್ ಕಮ್ ಬ್ಯಾಕ್? ಆ್ಯಂಡ್ ದ್ಯಾಟ್ಸ್ ದ ರೋಲ್ ಆಫ್ ಬೋನ್ ಮ್ಯಾರೋ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್. So in certain indications like myeloma, lymphoma, leukemia and so many other disorders of childhood, when we do bone marrow transplant, that's one of the treatment to take the response to the next level. Deep response ಸಿಕ್ಕಿದ್ರೆ chances of recurrence and relapse ಬಹಳ ಕಡಿಮೆ ಆಗುತ್ತೆ. That's the power of doing stem cell transplant. So autologous stem cell transplant ಅಂದ್ರೆ patient's own stem cells are taken, then high dose chemo is given, then after some time we give the stem cell back to the patient. So what happens? See, bone marrow is what it is like a factory, as Dr. Neema has told very nicely. It's a factory from where all the cells will come, even red blood, white blood, whatever cells, right? But from there bad cells will also come, good cell will also come, bad cell will also come. Bad cell will be killed by the chemo which we give, high dose, right? Now once we ensure that the high dose chemo is given and the factory is clear, it's like a garden. Factory is clear, the garden is clear, all the weeds have been removed, grass, ye wo patti jhad sab nikal diya, right? Now the playground is clear. Ee playground clear ಮಾಡಿ then we put the bija. Like a farmer will sow the seeds. adu playground clear ಆದ್ಮೇಲೆ when we put the seeds, then these seeds will form new crops. That is called healthy marrow. So patient having a diseased marrow now will make healthy marrow. This is how bone marrow transplant happens. So autologous stem cell transplant alli jaasti risk iralla because it is on patient's own stem cells. The chances of infection and having death and mortality is very, very low. But some period will be there where immunity will be low for about a week. In that case we have infection control and one-on-one care, all that things, antibiotics, supportive care. Adralli we take care that the patient's stem cell transplant is successful. I hope I am clear. Yeah. We will have questions later. So stem cell transplant is nothing but a very powerful way. We are taking the powerful pluripotent stem cell of the patient and making sure patient's own healthy marrow is formed from the stem cell. Thank you.
ಈ ಗಣ್ಯರಿಗೂ ಆರ್ಥಿಕ ಸುಸ್ವಾಗತಗಳು. ನನ್ನ ಹೆಸರು ಡಾಕ್ಟರ್ ಆದಿತ್ಯ ಅಂತ. ಕಳೆದ ಅರ್ಧ ಗಂಟೆಯಲ್ಲಿ ಈ ಸ್ಟೆಮ್ ಸೆಲ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟು, ಈ ಬೋನ್ ಮ್ಯಾರೋ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ಬಗ್ಗೆ ಬಹಳಷ್ಟು ನಾವು ಮಾಹಿತಿ ತಿಳ್ಕೊಂಡಿದ್ದೀವಿ. ಮುಖ್ಯವಾಗಿ ನಾನು
ಇವತ್ತು ತಿಳಿಸ್ಬೇಕಾದಂಥ ಒಂದು ಟಾಪಿಕ್, ಒಂದು ಸ್ಪೆಸಿಫಿಕ್ ಕ್ವೆಶನ್ ಅನ್ನೋದು ಅದು ಅಲೋಜೆನಿಕ್ ಬೋನ್ ಮ್ಯಾರೋ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ಅಂತ. ಎಲ್ಲಿ ಯಾವುದೇ ಒಂದು ರೋಗದಲ್ಲಿ, ಅದು ರಕ್ತಕ್ಕೆ ಸಂಬಂಧಪಟ್ಟ ಯಾವ ರೋಗ ಬೇರೆ ಯಾವುದಕ್ಕೂ ಬಗ್ಗಲ್ವೋ ಆ ಒಂದು ಸಿಚುವೇಷನಲ್ಲಿ ಮಾಡುವಂಥ ಒಂದು ಟ್ರೀಟ್ಮೆಂಟ್ ಈ ಅಲೋಜೆನಿಕ್ ಬೋನ್ ಮ್ಯಾರೋ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್. ಸೊ ಎಲ್ಲಿ ರೆಸಿಸ್ಟೆಂಟ್ ಲಿಂಫೋಮಾ ಇರುತ್ತೆ, ಎಲ್ಲಿ ರೆಸಿಸ್ಟೆಂಟ್ ಲುಕೀಮಿಯಾ ಇರುತ್ತೆ, ಎಲ್ಲಿ ಒಂದು ಬೋನ್ ಮ್ಯಾರೋ ಫೇಲ್ಯೂರ್ ಸಿಂಡ್ರೋಮ್ ಇರುತ್ತಲ್ಲ, ಅಲ್ಲಿ ನಾವು ಈ ಅಲೋಜೆನಿಕ್ ಬೋನ್ ಮ್ಯಾರೋ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ಅಂತ ಮಾಡ್ತೀವಿ. ಅಲೋಜೆನಿಕ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ಅಂದರೆ ಏನಪ್ಪ? ಈಗ ಫಾರ್ ಎಕ್ಸಾಂಪಲ್ ನೋಡಿ, ನಿಮ್ಮ ಯಾರದೇ ಮನೇಲಿ ಕಂಪ್ಯೂಟ್ರು ಕ್ರ್ಯಾಶ್ ಆಗಿಬಿಡತ್ತೆ, ವೈರಸ್ ಬಂದುಬಿಟ್ಟು, ಅವಾಗ ಏನು ಮಾಡೋದು? ನಾವು OS ಆಪ್ರೇಟಿಂಗ್ ಸಿಸ್ಟಮ್ನ ಡಿಲೀಟ್ ಮಾಡಿ ಫ್ರೆಶ್ ಆಗಿ ಆಪ್ರೇಟಿಂಗ್ ಸಿಸ್ಟಮ್ನ ಲೋಡ್ ಮಾಡ್ತೀವಿ. ಈ ಅಲೋಜೆನಿಕ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ಅನ್ನೋದು ಅದೇ ವಿಧದ್ದು ಒಂದು ಟ್ರೀಟ್ಮೆಂಟ್ ಪ್ಲ್ಯಾನು. ಅಲ್ಲಿ ಜೆನೆಟಿಕಲಿ ಮ್ಯಾಚ್ ಇರುವಂಥದ್ದು, ಇಲ್ಲ ಒಡ ಹುಟ್ಟಿರೋರಾಗಲಿ, ಇಲ್ಲ ಅಂದರೆ ಮ್ಯಾಚ್ ಇರುವಂಥ ಒಂದು ಸ್ಟ್ರೇಂಜರ್ಸ್ ಆಗಲಿ, ಇಲ್ಲ ನಮ್ಮ ತಂದೆ ತಾಯಿ, ಇಲ್ಲ ನಮ್ಮ ಮಕ್ಕಳಿಂದ, ಯಾವತ್ತು ತಂದೆ ತಾಯಿ ಆಗಲಿ ಇಲ್ಲ ಮಕ್ಕಳಾಗಲಿ ಅರ್ಧ ಅಟ್ಲೀಸ್ಟ್ ಮ್ಯಾಚ್ ಇದ್ದೇ ಇರುತ್ತೆ. ಯಾಕೆಂದರೆ ನಮ್ಮ ಅರ್ಧ ಭಾಗದ ಜೀನ್ಸ್ ನಮ್ಮ ಮಕ್ಕಳಿಗೆ ಇಲ್ಲ ನಮ್ಮ ತಂದೆ ತಾಯಿಗೆ ಹೋಗೇ ಇರುತ್ತೆ. ಅವರಿಂದ ಈ ಸೆಲ್ಸನ್ನು ತಗೊಂಡು ನಮ್ಮ ದೇಹದ ಓವರಾಲ್ ಆಪರೇಟಿಂಗ್ ಸಿಸ್ಟಮ್ ನಾವು ಬದಲಾಯಿಸೋಕ್ಕೆ ಪ್ರಯತ್ನ ಮಾಡ್ತೀವಿ. ಸೊ ದಿಸ್ ಈಸ್ ವಾಟ್ ಅಲೋಜೆನಿಕ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ಇಸ್. ಸೊ ಇದು ಲುಕೀಮಿಯಾ ಆಗಲಿ, ಇಲ್ಲ ಯಾವುದೇ ಒಂದು ಪದೇ ಪದೇ ಬರುವಂಥ ರೋಗ ಆಗಲಿ, ಇಲ್ಲ ಕಾರ್ಟಿ ಥೆರಪಿ ನಂತರ ಮತ್ತೆ ಬಂದಿರುವಂಥ ರೋಗ ಆಗಲಿ, ಸೊ ದ ಮೋಸ್ಟ್ ರೆಸಿಸ್ಟೆಂಟ್ ಕೇಸಸ್ಗೆ ಇರುವಂಥ ದ ಮೋಸ್ಟ್ ಕಾಂಪ್ಲಿಕೇಟೆಡ್ and the most critical treatment is available today in Apollo Bone Marrow Transplant Unit. ಸೊ ಈ ವಿಷಯದ ಬಗ್ಗೆ ಮಾತಾಡಲಿಕ್ಕೆ ನಿಮ್ಮೆಲ್ಲರನ್ನೂ ಇವತ್ತು ಕರೆದಿದ್ದು. ಈ ಸಂದರ್ಭದಲ್ಲಿ ಮತ್ತೊಂದು ಮುಖ್ಯವಾದ ಟಾಪಿಕ್ ನಾನು ಏನು ಹೇಳಬೇಕಂದ್ರೆ, ಎಲ್ಲರ ಮನಸ್ಸಲ್ಲಿ ಒಂದು ಮೂಢನಂಬಿಕೆ ಇದೆ, ಇದು ಒಂದು ವಿಧದ ಆಪರೇಷನ್ನ ಅಂತ ಅಂದ್ಬಿಟ್ಟು. ಇಲ್ಲ, ಇದು ಆಪರೇಷನ್ ಅಲ್ಲ. ವಿಚ್ ಮೀನ್ಸ್ ದ ಡೋನರ್ ಈಗ ಕಿಡ್ನಿ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟಲ್ಲಿ ಡೋನರ್ ಕಿಡ್ನಿ ಕೊಟ್ಟರೆ ಡೋನರ್ ಏನಪ್ಪ ಆಗಿಬಿಡತ್ತೆ, ಇಲ್ಲ ಡೋನರ್ ಲಿವರ್ ಕೊಟ್ಟರೆ ಡೋನರ್ ಏನಪ್ಪ ಆಗಿಬಿಡತ್ತೆ ಅಂತ ಅದು ಒಂದು ಮನಸ್ಸಲ್ಲಿ ಒಂದು ಭಯ ಇರುತ್ತೆ. ಇಲ್ಲಿ ಡೋನರಿಗೆ ಯಾವುದೇ ವಿಧದ ತೊಂದರೆ ಆಗೋದಿಲ್ಲ. ಸೊ ದ ಡೋನರ್ ಫಾರ್ ಅಲೋಜೆನಿಕ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ಈಸ್ ಜಸ್ಟ್ ಲೈಕ್ ಡೊನೇಟಿಂಗ್ ಫಾರ್ ಅ ಬ್ಲಡ್. ಯಾರು ಒಂದು ಬ್ಲಡ್ ಇಲ್ಲ ಒಂದು ಪ್ಲೇಟ್ಲೆಟ್ ಡೊನೇಷನ್ ಮಾಡ್ತಲ್ಲ, ಅದೇ ವಿಧದ ಮತ್ತೊಂದು ಡೊನೇಷನ್ ಇದು ಸ್ಟೆಮ್ ಸೆಲ್ಸು. ಯಾವ ಸೆಲ್ಲು ಸ್ಪೆಸಿಫಿಕ್ ಸೆಲ್ಸು ನಮ್ಮ ಹತ್ರ ಈ ಆಧುನಿಕ ಟೆಕ್ನಾಲಜಿ ಇದೆ, ಟೆಕ್ನಾಲಜಿಯಲ್ಲಿ ಯಾವ ಅಗತ್ಯ ಇರುವಂಥ ಸೆಲ್ ಮಾತ್ರ ಬ್ಲಡ್ಡಿಂದ ಫಿಲ್ಟರ್ ಮಾಡಿ ಅದನ್ನು ತಗೊಂಡು ಅಗತ್ಯವಾದಂಥ ರೋಗಿಗೆ ಕೊಡೋದೇ ವಿನಃ ಎಲ್ಲ ಸೆಲ್ಸ್ನು ತೊಗೊಂಡ್ಬಿಟ್ಟು ಡೋನರಿಗೆ ಯಾವುದೇ ವಿಧದ ತೊಂದರೆ ಮಾಡುವಂಥ ಪ್ರೊಸೀಜರ್ ಅಲ್ಲ. ಮೋಸ್ಟ್ ಇಂಪಾರ್ಟೆಂಟ್ಲಿ ಇಲ್ಲಿ ನಾವು ಕೀಮೋಥೆರಪಿಯ ಸಹಾಯ ತಗೊಳ್ತೇವೆ, ರೇಡಿಯೇಷನ್ನ ಸಹಾಯ ತಗೊಳ್ತೀವಿ, ಟೋಟಲ್ ಬಾಡಿ ರೇಡಿಯೇಷನ್. ದಟ್ ಈಸ್ ಅಗೇನ್ ಅ ವೆರಿ ವೆರಿ ಕಾಂಪ್ಲಿಕೇಟೆಡ್ ಪ್ರೊಸೀಜರ್. ಎಲ್ಲ ಆಸ್ಪತ್ರೆಗಳು ಸಿಗುವಂತ ಅಲ್ಲ. ವಿ ಹ್ಯಾವ್ ದ ಫೆಸಿಲಿಟಿ ವೆರಿನ್ ವಿ ಕ್ಯಾನ್ ಗಿವ್ ಸ್ಪೆಸಿಫಿಕ್ ಟೋಟಲ್ ಬಾಡಿ ರೇಡಿಯೇಷನ್ ಕೊಡಬಹುದು. ಕೊಟ್ಟಿದ ನಂತರ ನಾಟ್ ಜಸ್ಟ್ ಪುಟಿಂಗ್ ದ ನ್ಯೂ ಸೆಲ್ಸ್, ಬಟ್ ಈ ಹೊಸ ಸೆಲ್ಲು ಬೇರೆ ಅಗತ್ಯವಾದಂಥ ಗ್ರಾಫ್ಟ್ ವರ್ಸಸ್ ಲುಕೀಮಿಯಾ ಎಫೆಕ್ಟ್, ಅಂದರೆ ಯಾವುದೇ ಒಂದು ರೆಸಿಸ್ಟೆಂಟ್ ಸೆಲ್ ಇದ್ರೂ ಅದರ ವಿರುದ್ಧ ಹೋರಾಡಲಿಕ್ಕೆ ನಮ್ಮ ಜೆನೆಟಿಕಲಿ ಮ್ಯಾಚ್ ಸೋರ್ಸಿಂದ ನಾವು ವಿ ಆರ್ ಯೂಸಿಂಗ್ ದಟ್ ಆಸ್ ಅ ವೆಪನ್. ಸೊ ಅಲ್ಟಿಮೇಟ್ಲಿ ಅಲೋಜೆನಿಕ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ಅನ್ನೋದು ಯಾವುದು ಮೋಸ್ಟ್ ಕ್ರಿಟಿಕಲ್, ದ ಮೋಸ್ಟ್ ರೆಸಿಸ್ಟೆಂಟ್ ರಕ್ತಕ್ಕೆ ಸಂಬಂಧಪಟ್ಟಂಥ ರೋಗ ಇರುತ್ತೋ ಅದಕ್ಕೆ ಇರೋ ನಮ್ಮ ರಾಮಬಾಣ, ಒಂದು ಬ್ರಹ್ಮಾಸ್ತ್ರ ಅಂದರೆ ಇದು ಅಲೋಜೆನಿಕ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ಅಂತ. ಈ ವಿಷಯದ ಬಗ್ಗೆ ಇದು ಬಹಳ ಕಾಂಪ್ಲಿಕೇಟೆಡ್. ಇದ್ರ ಬಗ್ಗೆ ಇನ್ನೂ ಡೀಟೇಲ್ ಮಾಡೋದಕ್ಕಿಂತ ನಿಮ್ಮಲ್ಲಿ ಏನೋ ಪ್ರಶ್ನೆಗಳಿತ್ತು ಅಂದರೆ ಅದಕ್ಕೆ ಉತ್ತರ ಕೊಡಲಿಕ್ಕೆ ಸಹಜವಾಗಿರ್ತೇವೆ. ಥ್ಯಾಂಕ್ ಯು.
Thank you, Doctor. A visionary leader plays an instrumental role in driving Apollo's oncology mission across India and beyond. Ladies and gentlemen, I invite Mr. Akshay Oleti, CEO, Karnataka region, to deliver the keynote address for this auspicious event. Over to you, sir.
Thank you, Dr. Anu. A warm greeting to all the dignitaries and thank you for everyone to join us today on this auspicious occasion. Today we are celebrating multiple things, but this is the second event in oncology that we are having in a short span of 3 weeks now. The reason we are having also is because oncology as a specialty is also continuously evolving. You see cardiac, you see neuro, you see gastro. The new techniques of treating patients have long dried up over the last couple of decades. What was invented in 1990s are being followed now, and yes, definitely there are some improvements, but nothing is as rapid as oncology. What is happening in oncology? As you all know, cancer is the biggest focus now. Cancer is also one of the leading causes for deaths in the world, and everyone is working together to see how we can do path-breaking stuff, how we can make sure that we are able to provide the latest and greatest treatments for cancer. Now, today actually, for the cellular therapy and the bone marrow transplant unit launch, we wanted to have this press meet in the hospital because we have built a state-of-the-art bone marrow transplant unit in our facility where we can do not only the regular work but also really advanced work like the therapies that our doctors spoke with. Now, obviously it will be a lot more convenient to meet all of you here, and that is why we have done the event in this venue. But we also welcome each one of you to our hospital where we can take you on a tour to the comprehensive oncology capabilities that our hospitals have. Apart from this, I would also like to highlight the multidisciplinary team, a glimpse of which you are seeing on this stage. This stage itself has the who's who of talent that you can find anywhere in the world in the treatment of oncology. And even beyond this, we have many more wonderful clinicians in the Apollo Cancer Center network. Now, going beyond this, what we also want to tell very clearly is the launch of cellular therapy. Now, as you can see, we started by giving medicines to treat diseases. Then we looked at how we can improve the body condition by adding more immunotherapy, more cancer resistant cells into the body. Then we looked at getting a donor who has healthy cells and getting that transplanted into the patient. Now we are looking at taking a blood sample from the patient, giving it to a lab, adding immune cells to that blood and then transplanting it back to the patient. I'm sure in 5 years' time, oncology would have evolved even further. Most of the new technologies that come in at that particular point of time, we might not even have heard. So what Apollo Cancer Center is doing is, together we are trying to make sure that the best of treatment capabilities, the best of treatment skills are all housed in one place. And by doing this, we are making sure that the patients all around the world are getting the best treatment. And together with all the doctors, with the best infrastructure, and always looking at providing the best service and best service to the patients is what is making us lead this entire program. So I'd also like to thank the support of the entire senior leadership of Apollo, including Mr. Dinesh Madhavan, who unfortunately could not be here, along with the corporate office support, including Dr. Madhu and the promoters, who have helped in making sure that we are providing the path-breaking technology as well as clinical capabilities to the community. So I thank all of them, and I thank all of you also for coming here for the launch of the cellular therapy and the bone marrow transplant. Thank you.
Kinds of donors. ಒಂದು ಒಡ ಹುಟ್ಟಿದವರು ರಿಲೇಟೆಡ್ ಡೋನರ್ಸ್ ಆರ್ ವಾಟ್ ವಿ ಕಾಲ್ ಆಸ್ ಮ್ಯಾಚ್ಡ್ ಸಿಬ್ಲಿಂಗ್ ಡೋನರ್ಸ್ ಅಂತ, ಮತ್ತೊಂದು ಮ್ಯಾಚ್ಡ್ ಅನ್ರಿಲೇಟೆಡ್ ಡೋನರ್ಸ್ ಅಂತ. ಸೊ in India there is about 8 to 10% chance that any of the 140 crore Indians may have a genetic match with me. So henge now identify marti andre, it is either by a blood test or by a buccal swab test. One of these ways we do something called as a HLA typing anta helತೀವಿ. So this is ನಮ್ಮ source code. ಯಾವುದೇ ಒಂದು ಕಂಪ್ಯೂಟರ್ ಲ್ಯಾಂಗ್ವೇಜ್ ಮಾಡಿದ್ರೆ ಸೋರ್ಸ್ ಕೋಡ್. ಸೊ ಎರಡು ಸೋರ್ಸ್ ಕೋಡ್ ಮ್ಯಾಚ್ ಆಗತ್ತಾ ಆಗಲ್ವಾ ಅಂತ ನೋಡ್ತೀವಿ. The chances of having a HLA match with a sibling, with a brother or a sister, is about 30%. In a wide population, it is much lesser in India. So, India there are 2 or 3 unrelated donor registries. ಈಗ ಹೆಂಗೆ ಬ್ಲಡ್ ಬ್ಯಾಂಕ್ ಇದೆಯಲ್ಲ, ಅದೇ ಥರದ್ದು there are donor registries are also there. So obviously ನಮ್ಗೆ ಹೆಂಗೆ ಅಂತ ಅಂದರೆ, ಯಾರಾದರೂ ಒಡೋಟಿಯವ್ರು ಸಿಕ್ತು ಅಂದರೆ, it is easier for us to take their cells and give it. That way, that is one of the ways of finding a match. ಇಲ್ಲ ಅಂತಂದರೆ ಈ ಡೋನರ್ ರಿಜಿಸ್ಟ್ರೀಸಿಂದ ವಿ ಕಾಂಟ್ಯಾಕ್ಟ್ ದೆಮ್ ಆ್ಯಂಡ್ ವಿ ಗೆಟ್ ದೆಮ್. ಬಟ್ ಎಸ್, ದ ಸೆಕೆಂಡ್ ಪಾರ್ಟ್ ಆಫ್ ಯುವರ್ ಕ್ವೆಶನ್ ಇಸ್, ಯಾರು ಡೊನೇಟ್ ಮಾಡೋಕ್ಕೆ ಬರ್ತಾರಲ್ಲ ಅವ್ರು ಅಗತ್ಯ ಆಗುವಂಥ ಏನೇನು ಸೌಲಭ್ಯತೆ ಇದೆ ಎಲ್ಲದನ್ನು ಪ್ರೊವೈಡ್ ಮಾಡ್ತೀವಿ. ಟು ಬಿ ಆನೆಸ್ಟ್, ಇಟ್ ಇಸ್ ನಾಟ್ ಸೋ ಕಾಂಪ್ಲಿಕೇಟ್ ಫಾರ್ ಅ ಡೋನರ್. ಈಗ again, to take the example of a kidney transplant or liver transplant, ಡೋನರ್ಗೆ ಡೊನೇಟ್ ಮಾಡಿದ ನಂತರ ಅವ್ರಿಗೆ ಒಂದು ಗಾಯ ಇರುತ್ತೆ, ಹೀಲ್ ಆಗಬೇಕು, ಹಾಸ್ಪಿಟಲ್ 4-5 ದಿವಸ ಇರಬೇಕು, ಲಾಂಗ್ ಟರ್ಮ್ ಕಾಂಪ್ಲಿಕೇಶನ್ಸ್ ಇರುತ್ತೆ. ಬಟ್ ಫಾರ್ ಅ ಡೋನರ್ ಆಫ್ ಅ ಬೋನ್ ಮ್ಯಾರೋ ದೇರ್ ಇಸ್ ನಥಿಂಗ್ ಕಾಲ್ಡ್ ಆಸ್ ಅ ಲಾಂಗ್ ಟರ್ಮ್ ಕಾಂಪ್ಲಿಕೇಶನ್. ಆ ಥರ ಏನೂ ಇಲ್ಲ. 3-4 ದಿವಸ ಇಂಜೆಕ್ಷನ್ ತೊಗೊಳ್ತಾರೆ, 5 ದಿವಸ ರಕ್ತ ಕೊಡೋತಾರೆ, ರಕ್ತ ಕೊಟ್ಟು ಅವತ್ತೇ ಮನೆಗೂ ಹೋಗ್ಬೋದು. ಸೊ ಆ ಥರ ಪ್ರೊಲಾಂಗ್ಡ್ ಮೆಡಿಕಲ್ ಕೇರ್ ಆಗಲಿ ಸ್ಟೇ ಆಗಲಿ ಏನಾಗುತ್ತೆ. ಐ ಹೋಪ್ ದಟ್ ಆನ್ಸರ್ಸ್ ಯುವರ್ ಕ್ವೆಶ್ಚನ್.
But coming to your BMT, I know the process, as doctor mentioned, it's not an easy process. It's a little complicated. How expensive? I know it will vary from patient to patient, but in general, how expensive this whole process will be?
So by and large, the expenses do depend on why we are doing each particular transplant, right? For example, ಈಗ ಒಂದು ವಿಧ ರಕ್ತ ಕ್ಯಾನ್ಸರ್ ಅದಕ್ಕೆ ನಾವು ಮೈಲೋಮಾ ಅಂತ ಅಂದರೆ ಅದಕ್ಕೆ ಎಕ್ಸ್ಪೆನ್ಸಸ್ ವಿಲ್ ಗೋ ಎನಿವೇರ್ ಫ್ರಮ್ 8 to 10 lakhs. ಅದೇ ನಾವು ಲುಕೀಮಿಯಾ ವಿಚ್ ಇಸ್ ಅ ಮಚ್ ಮೋರ್ ಕಾಂಪ್ಲಿಕೇಟ್ ಒನ್ ವೇರ್ ಪೇಷಂಟ್ಗೆ ಸಪೋರ್ಟ್ ಬಹಳ ಬೇಕಾಗತ್ತೆ, ಇಟ್ ಮೈಟ್ ಬಿ ಅ ಲಿಟಲ್ ಬಿಟ್ ಮೋರ್. ಸೊ ರಾದರ್ ದೆನ್, ಸೊ ವಾಟ್ ಐ ವಾಂಟ್ ಆಲ್ ಆಫ್ ಅಸ್ ಹಿಯರ್ ಇಟ್ ಈಸ್, ಡೋಂಟ್ ಫೋಕಸ್ ಆನ್ ದ ಟಿಕೆಟ್ ಪ್ರೈಸ್. ಈಗ ಹೆಂಗೆ ಅಂದರೆ ಒಂದು ಕಿಡ್ನಿ ಟ್ರಾನ್ಸ್ಫರ್ ಅಂದರೆ ಪ್ಯಾಕೇಜ್ ಇಷ್ಟು, ಲಿವರ್ ಟ್ರಾನ್ಸ್ಫರ್ ಇಷ್ಟು ಪ್ಯಾಕೇಜ್. ಸೊ ಇಟ್ ಈಸ್ ನಾಟ್ ಅಬೌಟ್ ಅ ಪ್ಯಾಕೇಜ್, ದಿಸ್ ಈಸ್ ಅಬೌಟ್ ಎಷ್ಟು ಸಪೋರ್ಟ್ ಬೇಕಾಗುತ್ತೆ ಪೇಷಂಟಿಗೆ, ಎಷ್ಟು ದಿವಸ ಐ ಸಿ ಯುಲಿ ಇರುವಂಥ ಅಗತ್ಯತೆ ಇದೆ, ಎಷ್ಟು ಬ್ಲಡ್ ಪ್ರಾಡಕ್ಟ್ಸ್ ಬೇಕಾಗುತ್ತೆ, ಎಷ್ಟು ಆ್ಯಂಟಿಬಯೋಟಿಕ್ಸ್ ಬೇಕಾಗುತ್ತೆ. ಸೊ ಇಟ್ ಈಸ್ ಅ ರಿಯಲಿ ವೇರಿಯಿಂಗ್ ಥಿಂಗ್. ಅದು ಒಂದು. ಎರಡನೇದು, ಹಣ ಎಷ್ಟೇ ಆಗಲಿ, ಇಫ್ ಇಟ್ ಇಸ್ ಅ ಕ್ಯೂರೇಟಿವ್ ಇಂಟೆಂಟ್, ಯಾರನ್ನಾರು ನಾವು ಕ್ಯೂರ್ ಮಾಡೋ ಒಂದು ಪ್ರಯತ್ನ ಇತ್ತು ಅಂದರೆ ದೇರ್ ಆರ್ ವೇಸ್ ಟು ರೇಸ್ ಫಂಡ್ಸ್. ಮಾನ್ಯ PM ಫಂಡ್ ಇದೆ, CM ಫಂಡ್ ಇದೆ, ಎಷ್ಟೋ ಒಂದು NGOs ಆರ್ ವರ್ಕಿಂಗ್ ಫಾರ್ ಅಸ್ಸು. ಈ ಸೋಷಿಯಲ್ ಮೀಡಿಯಾ ಮೇಲ್ಗಡೆ ದೇರ್ ಆರ್ ಮೆನಿ ಪ್ಲಾಟ್ಫಾರ್ಮ್ಸ್ ಟು ಡೂ. ಸೊ see, cost is an issue, but it is never a barrier. Let us not make that as a barrier.
Okay, last question. How the center will contribute to Apollo's broader research goals in this rapidly evolving, field?
So our transplant and cellular therapy unit will be a registered signatory or a contributory authority to the global or the national Indian bone marrow transplant program. So India has a ISBMT anta, there is a Indian stem cell transplant registry thara ide. So we will not only contribute our data, namma outcomes, namma experience nu kodteve, so that because see, as all my colleagues have pointed out, this is a very niche specialty. Number of people who are doing this in the country is very less. So when we share experiences, the outcomes are better. ಯಾಕೆಂದರೆ ಪ್ರತಿಯೊಂದು ಬೋನ್ ಮ್ಯಾರೋ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟಲ್ಲಿ ಇಟ್ಸ್ ನಾಟ್ ದಟ್ ಕ್ಯೂರ್ ಮಾಡೋದು ಅಷ್ಟೇ ಅಲ್ಲ ತೊಂದರೆ. ಅದು ತೊಂದರೆ ಈಸ್ ಇನ್ಫೆಕ್ಷನ್ ವಿರುದ್ಧ ಹೆಂಗೆ ಹೋರಾಡೋದು. ಯಾಕೆಂದರೆ ಎಷ್ಟೇ ಒಂದು ನ್ಯೂವರ್ ಮಲ್ಟಿ ಡ್ರಗ್ ರೆಸಿಸ್ಟೆಂಟ್ ಇನ್ಫೆಕ್ಷನ್ಸ್ ಎಲ್ಲ ಬರ್ತಾ ಇದೆ. ಸೊ ಅದರ ವಿರುದ್ಧ ವಾಟ್ ಆರ್ ದ ಸ್ಟ್ರಾಟಜೀಸ್ ದಟ್ ವಿ ಹ್ಯಾವ್, ಅದನ್ನು ಪೂಲ್ ಅಪ್ ಮಾಡ್ತೀವಿ. ಯಾವ್ದಾದ್ರು ಇದೆಯಾ ಇಲ್ಲ ಅಂತ ಸ್ಕ್ರೀನ್ ಮಾಡ್ತೀವಿ. ಎಸ್ಪೆಷಲಿ ನಮ್ಮಲ್ಲಿ ಇಂಡಿಯಾಲಿ ಇವತ್ತಿನ ಡೇಟಲ್ಲೂ TBದು ಸಾಂಕ್ರಾಮಿಕ ರೋಗ, TB ಅನ್ನೋದ್ರದ್ದು ದ ಪ್ರಿವೆಲೆನ್ಸ್ ಭಾಳ ಜಾಸ್ತಿ ಇದೆ. ಇನ್ಫ್ಯಾಕ್ಟ್ ಚಿಕ್ಕ ವಯಸ್ಸಲ್ಲಿ ಯಾವಾಗಲೂ ನಮಗೆ TB ಬಂದಿರಬಹುದು, ಬಟ್ ಲೇಟೆಂಟ್ ಆಗಿ ದೇಹದಲ್ಲೇ ಉಳ್ಕೊಂಡು ಬಿಟ್ಟಿರತ್ತೆ, ಅದು ಪೂರ್ತಿ ಗುಣ ಆಗಿರೋದಿಲ್ಲ. ಸೊ ವಿ ಚೆಕ್ ದ ಬಾಡಿ ಫಾರ್ ಎನಿ ಪ್ರೀ ಎಕ್ಸಿಸ್ಟಿಂಗ್ ವೈರಲ್ ಇನ್ಫೆಕ್ಷನ್ಸ್ ಆರ್ ಪ್ರೀ ಎಕ್ಸಿಸ್ಟಿಂಗ್ TB ಥರ ಇನ್ಫೆಕ್ಷನ್ಸ್. ಆ್ಯಂಡ್ ಇಫ್ ದೋಸ್ ಇನ್ಫೆಕ್ಷನ್ಸ್ ಆದರೆ ಅವನ್ನು ಫಸ್ಟು ಟ್ರೀಟ್ ಮಾಡಿ ಅದು ಪೂರ್ತಿ ಸರಿಯಾಗಿದ್ದ ನಂತರನೇ ತೊಗೊಳೋದು. ಬಿಕಾಸ್ ಪೋಸ್ಟ್ ದ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟು ದೇಹ ಒಂದು ಹೊಸ ಶಿಶು ಥರ, ದೇರ್ ಈಸ್ ನೋ ಇಮ್ಯುನಿಟಿ. ಇನ್ಫ್ಯಾಕ್ಟ್ ಪೋಸ್ಟ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ಜನರಿಗೆ ನಾವು ವ್ಯಾಕ್ಸಿನೇಷನ್, ಇಮ್ಯುನೈಸೇಷನ್ ಅದು ಪೂರ್ತಿ ಮಕ್ಕಳಿಗೆ ಮಾಡೋ ಥರ ಪೂರ್ತಿ ಇಮ್ಯುನೈಸೇಷನ್ ಸಹ ಮತ್ತೆ ಮಾಡ್ತೀವಿ ನಾವು. ಸೊ ಕೀಪಿಂಗ್ ದಟ್ ಇನ್ ಮೈಂಡ್, ವಿ ಹ್ಯಾವ್ ಟು ಟ್ರೀಟ್ ದ ಇನ್ಫೆಕ್ಷನ್, ಮೇಕ್ ದ ಪೇಷಂಟ್ ಫಿಟ್ ಆ್ಯಂಡ್ ಓನ್ಲಿ ದೆನ್ ಟೇಕ್. ಇಲ್ಲ ಫಿಟ್ ಆಗಿಲ್ಲ ಅಂದರೆ ತೊಗೊಳೋದು. ಅದೇ ಹೇಳಿದ್ರಲ್ಲ, ಈಗ ಲೆಟ್ಸ್ ಅಸ್ಯೂಮ್ 35 ವರ್ಷದ ಯಾರೋ ಒಬ್ರು ಜೆಂಟಲ್ಮೆನ್ನು ಪಾಪ ಯಾವುದೋ ಕಾರಣಕ್ಕೆ ಹಾರ್ಟ್ದು ಬಡಿತ ಸರಿ ಇಲ್ಲ. ಸೊ ಜಸ್ಟ್ ಬಿಕಾಸ್ ಈಸ್ 35 ಅವರಿಗೆ ನಾವು ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ಮಾಡೋಕ್ಕೆ ಹೋಗಲ್ಲ, ಬಿಕಾಸ್ ಹಾರ್ಟ್ ವಿಲ್ ನಾಟ್ ಸಸ್ಟೈನ್. ಇಟ್ಸ್ ಲೈಕ್ ದಟ್, ಸರ್.
What is the maximum age transfer?
So again, sir, to repeat it, it's about the biological age and not the chronological age. In our unit, we have done autologous transplants for people who are 70, 72 also. But not because they are 70 years old or we can do it, but because they are fit as a 50-year-old person.
ಈಗ ಇವೆಲ್ಲ ಆಪ್ಷನ್ ಕೊಟ್ಟಿರೋದ್ರಿಂದ ಮತ್ತೆ ಈ ರೋಬೋಟಿಕ್ ಏನು ವಿಚಾರಗಳನ್ನ ಬರ್ತದೆ
ರುಮ್ಯಾಟಿಕ್ ವಿಷಯಕ್ಕೆ ಇದಕ್ಕೆ ಅಷ್ಟೇ ರೋಬೋಟಿಕ್ ಇಲ್ಲ, ಇದರಲ್ಲಿ ಸರ್ಜರಿ ಇಲ್ಲ. ಸೊ ಇದರಲ್ಲಿ ಏನು ಅಡ್ವಾನ್ಸು, ಸೊ ರೋಬೋಟಿಕ್ ಅಂತ ಹೇಳೋಕ್ಕಲ್ಲ, ಬಟ್ ಇದರಲ್ಲಿ ದೇರ್ ಈಸ್ ಸಮ್ ಅಮೌಂಟ್ ಆಫ್ ನ್ಯೂವರ್ ಪ್ಲ್ಯಾನ್. ಸೊ ಇಫ್ ನೀವು ನನ್ನ ಡೋನರ್ ಇದ್ದೀರಾ, ಅವರು ನನ್ನ ಡೋನರ್ ಇದ್ದಾರೆ, ಬಟ್ ನನ್ನ B ಪಾಸಿಟಿವ್ ಬ್ಲಡ್ ಗ್ರೂಪ್ಗೆ ಅವ್ರು B ಪಾಸಿಟಿವ್ ಇತ್ತು ಅಂದರೆ ಐ ವುಡ್ ಪ್ರಿಫರ್ ದೆಮ್. ಸೊ ಫಸ್ಟ್ ಥಿಂಗ್ ಈಸ್ ಜೆನೆಟಿಕ್ ಮ್ಯಾಚ್ ಇರಬೇಕು. ನಮಗೆ ಬರೀ ನೀವೊಬ್ಬರೇ ಜೆನೆಟಿಕ್ ಮ್ಯಾಚ್ ಇಲ್ಲ, ಅವ್ರು ಜೆನೆಟಿಕ್ ಮ್ಯಾಚ್ ಇಲ್ಲ, ಸೊ ನಾನು ಎ ಇದ್ಬಿಟ್ಟು ನೀವು ಬಿ ಇದ್ರೂ ನಾನು ತೊಗೊಂಡು ಮಾಡ್ತೀನಿ. ಇನ್ಫ್ಯಾಕ್ಟ್ ಈವನ್ ರೈಟ್ ನೌ ವಿ ಆರ್ ಡೂಯಿಂಗ್ ಅ ಕ್ರಾಸ್ ABO ಮ್ಯಾಚ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ಮಾಡ್ತಾ ಇದ್ದೀವಿ, ಈವನ್ ರೈಟ್ ನೌ ಆಸ್ ವಿ ಸ್ಪೀಕ್. ಬಟ್ ದ ಥಿಂಗ್ ಇಸ್ ದಟ್ ಜೆನೆಟಿಕ್ ಮ್ಯಾಚಿಂಗ್ ಈಸ್ ನಂಬರ್ 1. ಸೆಕೆಂಡ್ ಈಸ್ ಯಂಗ್ ಏಜ್. ಸೊ ನೀವು ವಾಟ್ ಈಸ್ ದ ಐಡಿಯಲ್ ಡೋನರ್ ಕ್ರೈಟೀರಿಯಾ ಅಂತ, ಫಸ್ಟ್ ಕ್ರೈಟೀರಿಯಾ ಇಸ್ ಫುಲ್ ಜೆನೆಟಿಕ್ ಮ್ಯಾಚ್, ಸೆಕೆಂಡ್ ಕ್ರೈಟೀರಿಯಾ ಇಸ್ ಯಂಗರ್ ಏಜ್, ಥರ್ಡ್ ಕ್ರೈಟೀರಿಯಾ ಇಸ್ ಮೇಲ್ ಓವರ್ ಫೀಮೇಲ್, ಫೋರ್ತ್ ಕ್ರೈಟೀರಿಯಾ ಇಸ್ ಬ್ಲಡ್ ಗ್ರೂಪ್ ಮ್ಯಾಚಿಂಗ್.
ಯಾರೆಲ್ಲ ಅರ್ಹರಿಲ್ಲ ಡಾಕ್ಟರ್ ಇದಕ್ಕೆ?
ಸರ್ ಅರ್ಹರಿಲ್ಲ,
ಯಾರೆಲ್ಲ ಅರ್ಹರಿಲ್ಲ ಈ ಥೆರಪಿಗೆ?
ಅದೇ ದೇಹ ತಡಿಯಲ್ಲ ಅಂದರೆ ಅವರ ಅರ್ಹತೆ ಇಲ್ಲ ಅಷ್ಟೇ. ಇಟ್ ಈಸ್ ಓನ್ಲಿ ದ ಬಾಡೀಸ್ ಫಿಟ್ನೆಸ್.
ಡೊನೇಟ್ ಮಾಡ್ಲಿಕ್ಕೆ ಅಥವಾ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ಮಾಡಿಸ್ಕೊಳ್ಳಿಕ್ಕ?
ಎರಡಕ್ಕೂ.
ವೆರಿ ಸಿಮಿಲರ್ ಥಿಂಗ್ಸ್.
One last question, my question to the CEO. Since the US
So, Iga, in India, the cost is much lesser.
Yeah.
It is not the other way around.
Correct.
US only, France only, the cost is much higher.
Right.
There are multiple reasons why we are able to bring the cost down. One is because from a hospital standpoint, we want to cater to the society. Now, as to cost ittidre ಒಂದು ಪೇಷಂಟ್ ಟ್ರೀಟ್ ಮಾಡ್ತೀವಿ, ಬಟ್ ಅದು ಇಲ್ಲ. ದಟ್ ಇಸ್ ನಾಟ್ ದಿ ಅಬ್ಜೆಕ್ಟಿವ್. ದಿ ಅಬ್ಜೆಕ್ಟಿವ್ ಇಸ್ ಟು ಟ್ರೀಟ್ ಆಸ್ ಮೆನಿ ಪೀಪಲ್ ಆಸ್ ಪಾಸಿಬಲ್. ಸೊ ಇಟ್ ಇಸ್ ಇನ್ ಅವರ್ ಇಂಟ್ರೆಸ್ಟ್ ಟು ಕೀಪ್ ದ cost as low as possible. Plus there are multiple other things where even if you take medicines, the same drug components, right? Illi avaru generic anta madbittu, so the cost will be lower. The ecosystem in India, which includes the cost of the medicines, the cost of the manpower, all of those are substantially lower when it comes to the developed countries, and that is one of the reasons we are able to provide that level of care and still be profitable.
So which means you will be attracting the international patients?
Absolutely, yes. In fact,
What are the ways? Like how you will be
not
attracting?
only, see, I'll tell you, as hospitals, people think that okay, nam kade international patients baroreಲ್ಲ Africa inda, Bangladesh inda, Middle East inda irtare anta. There are people who are coming from UK, France and all these places also to our hospitals because one, accessibility ಇದೆ. UK ಅಲ್ಲಿ ನಿಮಗೆಲ್ಲ ವೇಟಿಂಗ್ ಟೈಮ್ ಏನಂತ ಗೊತ್ತು. ಇಲ್ಲಿ ಏನಾದರೂ ಈಗ ಪ್ರಾಬ್ಲಮ್ ನಮಗೆ ಯಾವ್ದಾದ್ರು ಇದ್ದರೆ ಇಮಿಡಿಯೇಟ್ಲಿ ಒಂದು 15 ಮಿನಿಟ್ಸಲ್ಲಿ ವಿ ಕ್ಯಾನ್ ಗೆಟ್ ದ ಫುಲ್ ಕೇರ್ ಆ್ಯಂಡ್ ಕಮ್ ಔಟ್ ಆಫ್ ದಿ ಹಾಸ್ಪಿಟಲ್. ಆ ಥರ ನಮ್ಮದು ಸಿಸ್ಟಮ್ಸ್ ಇದೆ. ವಿ ಆಲ್ವೇಸ್ ಥಿಂಕ್ ಇಂಡಿಯನ್ ಸಿಸ್ಟಮ್ಸ್ ಆರ್ ಬಿಲೋ ಪಾರ್, ಬಟ್ ಇಂಡಿಯನ್ ಸಿಸ್ಟಮ್ಸ್ ಆರ್ ವೆರಿ ಗುಡ್. ಕಾಸ್ಟ್ ಇಸ್ ಮಚ್ ಲೆಸ್ಸರ್ and the doctors are the best in the world. In fact, many of our doctors are trained in those places and come back and making sure that we are providing the best care. So cost will only keep going down, therapies will only keep getting better. India is the best place for health.
ಏನು 2 weeks ಯಾಕೆ ಬೇಕು ಅನ್ನೋದು, ಸೊ ಇದ್ರ ಬಗ್ಗೆ ನೀವು ಏನು ಹೇಳ್ತೀರಾ?
ಕರೆಕ್ಟ್. ಸೊ ಇದು ಪ್ಲಾನಿಂಗ್ ಸ್ಟೆಮ್ ಸೆಲ್ ಬಗ್ಗೆ ಇಟ್ ಸ್ಟಾರ್ಟ್ಸ್ ದ ಮೂಮೆಂಟ್ ದ ಡಯಾಗ್ನೋಸಿಸ್ ಆಫ್ ಡಿಸೀಸ್ ಹ್ಯಾಪನ್ಸ್. ಕಾಯಿಲೆ ಗೊತ್ತಾದ್ಮೇಲೆ ಟ್ರೀಟ್ಮೆಂಟ್ ಬಗ್ಗೆ ಮಾತಾಡ್ತೀವಿ, ಮುಂದೆ ಹೇಳ್ತೀವಿ, ಪ್ರಿಪೇರ್ ಮಾಡ್ತೀವಿ ಫ್ಯಾಮಿಲಿಗೆ ದಟ್ ಯು ವಿಲ್ ನೀಡ್ ಅ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ಆಫ್ಟರ್ 4-5 months. ಸೊ ಆ ಥರ ಪ್ರಿಪೇರ್ ಮಾಡುವಾಗ ಆಫ್ಟರ್ 4-5 months ಆಫ್ಟರ್ ಗಿವಿಂಗ್ ಟ್ರೀಟ್ಮೆಂಟ್ ದೇ ಗೆಟ್ ಸಪೋಸ್ ಗುಡ್ ರೆಸ್ಪಾನ್ಸ್. ಸೊ ದ ಪ್ರೊಸೀಜರ್ ಯು ಆರ್ ಆಸ್ಕಿಂಗ್ ಅಬೌಟ್ ದ ಸ್ಟೆಪ್ಸ್. ಸೊ ಜನರಲಿ ದ ಸ್ಟೆಪ್ಸ್ ಈಸ್ ಲೈಕ್ ದಿಸ್. ಒನ್ಸ್ ದ ಡಿಸೀಸ್ ಈಸ್ ಅಂಡರ್ ಗುಡ್ ರೆಮಿಷನ್, ಗುಡ್ ರೆಸ್ಪಾನ್ಸ್ ಸಿಕ್ಕಿದೆ ಪೆಟ್ ಸಿಟಿ ಸ್ಕ್ಯಾನಲ್ಲಿ, then we start something called, we start the screening. ಅಂದರೆ ಪೇಷಂಟ್ದು ಫುಲ್ ಬಾಡಿ ಚೆಕಪ್, ಬ್ಲಡ್ ಚೆಕಪ್, ಇನ್ಫೆಕ್ಷನ್ ಇರಬಾರ್ದು ಬಾಡಿಯಲ್ಲಿ, ಚೆಸ್ಟ್ ಎಕ್ಸ್ರೇ, ಲಂಗ್ ಫಂಕ್ಷನ್ ಟೆಸ್ಟ್, ಲಿವರ್ ಫಂಕ್ಷನ್ ಎಲ್ಲ ಚೆಕ್ ಮಾಡ್ತೀವಿ, ಹಾರ್ಟ್ ಫಂಕ್ಷನ್ ಬಿಫೋರ್ ದ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್. ದಿಸ್ ಇಸ್ ಕಾಲ್ಡ್ ಪ್ರೀ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ವರ್ಕಪ್. ಓಕೆ, ಈ ವರ್ಕಪ್ ಆದಮೇಲೆ ಇಟ್ ದಿಸ್ ಟೇಕ್ಸ್ 3-4 days. ಸಮ್ ವೈರಸಸ್ ಆಲ್ಸೋ ವಿಲ್ ಚೆಕ್ ಲೈಕ್ CMV, HIV, ಎವ್ರಿಥಿಂಗ್ ವಿಲ್ ಚೆಕ್. ಸೊ ಇದು ಎಲ್ಲ ನೆಗೆಟಿವ್ ಇರಬೇಕು. ಸೊ ಇದ ನಂತರ ವಿ ಸ್ಟಾರ್ಟ್ ದಮ್ ಆನ್ ಗ್ರೋತ್ ಫ್ಯಾಕ್ಟರ್ಸ್. ಗ್ರೋತ್ ಫ್ಯಾಕ್ಟರ್ ಅಂದರೆ ಸ್ವಲ್ಪ ಸಣ್ಣ ಸಣ್ಣ ಇಂಜೆಕ್ಷನ್ಸ್ ವಿ ಗಿವ್ ಮಾರ್ನಿಂಗ್ ಆ್ಯಂಡ್ ನೈಟ್ ಫಾರ್ 4 days. That is to mobilize the stem cell from the bone marrow to the blood. Patient will take it home. 3 days patient will take it home. 4th day admission irutte. 4th day admission agi ade dina we'll put a neck line, but which is a preparation for collecting the stem cells next day. The next day stem cells will be collected, which is a 4-hour procedure, just like any other. There's a machine and it's a simple procedure like dialysis. If you have seen dialysis machine, that is very big. This is very small, half this size. Okay? Just like a thing. So blood is circulating through the machine. The machine is programmed to collect the stem cell. A programming is there. So it will collect only stem cells. A stem cells collect 4 hours alli collect agutte. It goes to blood bank. After that, if it is a myeloma, we give chemo on the same day. If it is lymphoma, depending on the disease, the chemo is for the next 5 days. So usually if you take myeloma, which is a shorter stay, same day evening chemo koddivi, and the stem cell counting is done in the lab whether the collection is adequate or not. And other nantara chemo kottadmele next day only we'll give the stem cell back to the patient, just like blood transfusion. Okay, and after giving the stem cells, then there is a waiting period of 9 to 10 days. So what happens in this stem cell, in the waiting period, the count which was high, because we have given growth factors, really count had become high, but then we gave chemo, count will go down. It will go down to 4,000, 3,000, 100, 200, 0. And then it will start jumping 0, 100, 500, 1,000, 2,000. This process of coming down and going up, this is called engraftment. This engraftment period is 1 week to 10 days, 7 to 10 days. So in this, the lowest, when it is going down and coming up, so this lowest period, peak period, down peak, is the high risk because counts are low. In that case, we have to be very careful about any fever, infection. That is why patient is one-on-one care, BMT unit, single nurse, no many people entering, limiting the visiting of even relatives are not allowed. Only one sister and patient. After that, patient becomes better and patient goes home. So it takes 2.5 to 3 weeks maximum. This is autologous. Patient's own stem cells are given to the patient back. So it is like, as I explained, it is like clearing the ground.
Okay.
Ground is bone marrow. We cleared the bone marrow by giving chemo. And then we put new seeds, that is stem cell. The new seeds will form new crop, which is the healthy marrow.
And what are the precautions we need to do after the post-treatment?
So post-transplant, once the patient goes home, again, main thing is infection. Infection ಆಗಬಾರ್ದು. ಎಲ್ಲಿಂದ infection ಬರುತ್ತೆ? Food, air, water. ಹೊರಗಡೆದು ಊಟ ಮಾಡಬಾರ್ದು, ಹೊರಗಡೆದು ನೀರು ತಗೊಯ್ದು ಜ್ಯೂಸ್ ಗೀಸ್ ತಗೊಳ್ತಾರೆ, ನಾವು ಸ್ಯಾಲೆಡ್ ತಗೊಳ್ತಾರೆ, ಬಿರಿಯಾನಿ and all, chutney will come. All those uncooked items should be avoided. Basically, outside food nahi khana hai. Should not eat outside food. So food, air, water. Air, how? Don't go in the crowded, dusty places. Be at home. Don't go unnecessarily in dusty and crowded malls, shopping and all that. Homemade food, best. Cooked food and water. Water also we tell them, aquaguard to sabke ghar mein, but maintenance karao. There was no use of aquaguard with no maintenance. So, or boiled cool water. These are simple things, but food, air, water, if you take care, there will be no infection.
And we also put them on medicines so that ಹೊರಗಡೆ ಹೋದ್ರೂ
Infection barbard, prophylaxis ಕೊಡ್ತೀವಿ, some medicines to make sure that because the immunity is little low, so they will have a chance of infection that can be prevented by giving some medicines. That is called prophylaxis.